better sense of mental health. I'm sure all of us will appreciate that uh, we cannot provide health or social care without good understanding of mental health. So that is, if Arya, I was just thinking whether you want that first video to go when I say I'll introduce the topic, then we will try that first video. If it fails, of course, we will start the screen sharing. I'll ask Arya to start the video. Then only you start. Okay.
Okay, sir.
So all of you will see few conditions. The commonest one is depression. This is not only the commonest mental health problem, it is one of the commonest medical problems which human beings suffer from during their lifetime. It's as frequent as if you take people between 18 years and more, about 8% of the general population will have depressive symptoms and which would qualify for at least mild depressive episode, which we will discuss soon. Second point is that when someone else is or someone is seeking help for a medical problem, among such population, it will be something like 15 to 20%, meaning every fifth or sixth person you see in your outpatient setting should be suffering from at least a mild depressive episode. Uh, this video, which I am planning to, we will circulate this video to all participants. This is a video which has impressed all of us very much. This is a video made by the World Health Organization. If you could listen that, then we will know how less we know about depression. And sometimes we do not recognize depression, and then why sometimes we leave it untreated. Arya, can you try that video now? This
Okay,
is
sir,
a
I will
video
try.
called, yeah, I will try. This is a video called I Had a Black I Had a Black Dog. It's freely available in the internet. His name was Depression. Uh, this is a celebrated author. I think he's originally from Australia. He went through an episode of depression. Then he wrote a book on about his experience, and then WHO went ahead and made this video. Okay, we can see this was this actually this is the second video. There are two videos. If we have time, we will show you the first video later on. So I'll try to share my slides. Is it visible now?
Yes, sir, it's visible.
Okay. I saw the case which you are going to present briefly. So let us go through uh, a condition called depressive disorder. See, mental health problems are very common. The commonest is depression. We are only talking about depression today, and we will discuss anything else after this session. So it's about 3:14 now. Next few minutes, listen carefully. You can stop me anytime. Arya, you can ask me questions in between if somebody wants to stop me and ask.
Okay, sir. Sure, sir.
See, when you see someone in palliative care, there are three possibilities. One is that that person has depression uh, and a physical illness which you are handling. It is also possible that a person has only depression and lots of physical symptoms are there, which is due to depression and not due to any other illness. I presume that that will be less with palliative care practice, unlike primary care or secondary care. Then you will have people who do not have depression, meaning they have a life threatening disorder which you are treating, but no evidence of depression. Why is this important? We said that about 8% of adults have depressive disorder. Most of it is mild, but about 1% of them are severe. It is usually as depression rarely is seen alone. You have something like diabetes, hypertension, or a chronic disorder, and then you have superimposed depression. The most important thing about depression, which most health and social care practitioners do not understand, is that depression is eminently treatable. Even without treatment, by default, it gets remitted in most cases. So, depression is a condition which is common, treatable. Response to treatment is extremely good. Thirdly, even with treatment, it can remit by itself. The importance is that it causes severe personal distress, it affects quality of life, and thus it is very important to identify and correct or relieve depression. So, there are various interventions which are available. Sometimes pharmacological interventions are also useful, but you should know how to decide about the intervention which the person requires. And it's very important that you are able to communicate the diagnosis of depression as well as the need for treatment effectively and very clearly to the patient or family. See, I had been practicing psychiatry for more than 40 years now. Most often, the diagnosis of depression is missed. Sometimes this is getting treated as some physical illness. Sometimes the doctors will investigate this for vague physical symptoms. So most of the time, this is missed or misdiagnosed as something else. Next few minutes are very important for all health and social care practitioners. See, if I lose some money, or if there is some financial stress, or someone close to me dies, all of us will become unhappy. So, unhappiness is a normal human experience. Whereas, when do you call a unhappy state of mind as depression? So, this is very important. Depression is present when symptoms of depression are there. There are more than one symptom. And when the symptom count is above threshold, you would want to call this as a syndrome of depression. So, just by being unhappy for few days, you will not consider a diagnosis of depression. So, what is this depressive syndrome? So, there are two important criteria. One is that did someone wanted to say something? Arya, am I audible?
Yes, sir. You are audible, sir.
Audible?
Yes, sir.
Okay, okay. So these are broad criteria. One is that certain symptoms are a must, essential symptoms. Then there could be other symptoms which you can count as present or absent, and you will later see how many are present. Let us see. See, these are one of these symptoms should be present for anyone to meet the criteria for depression. First is persistent dysphoria. It means that most of the time during wakeful hours, most of the time means more than 50% of the time when I am awake, I am unhappy. Dysphoria means unhappiness, or my mood is low, unpleasant. More than 50% of the time during wakeful hours, during the day. Most of the days in a week are like that, meaning 4 or more days out of 7 days. And this has gone on for more than 2 weeks. Then unhappiness, which is persistent, which is present most of the time during the day, and which persists, which is experienced most of the days in a 2 week period, is considered as persistent dysphoria. This has to be present, or if that is not present, you can have what is known as pervasive loss of interest. The key word again, unlike the previous term, there it was persistent. Pervasive loss of interest means that you have lost interest in most activities of life, like eating, having, seeing movies, going for work, everything. So, all pervading loss of interest. Loss of interest means you had interest which made you do many things. Those things are no more interesting to you. If this symptom lasts for more than 2 weeks, most of the time during wakeful hours, for more than 2 weeks, most of the days in the last 2 weeks, then that will also qualify. So, one of these symptoms should be there to call this, to consider the diagnosis of depressive syndrome. So, I have made that definition very easy. It appears, meaning you can write down this if you read this many times in an exam. But it is not easy to elicit this presence of persistent dysphoria or pervasive loss of interest from a person who is sitting opposite to you, or you happen to, that person happen to seek. So you have to, I suggest that you learn how to ask about this, design your own method of eliciting this symptom in your own language, a language which you and the interviewed person can understand. And by practicing those questions during interview sessions, you will feel comfortable about asking those questions. And then it becomes routine. For the last 40 years, I am comfortable in asking these questions. I have standard set of questions with which I will elicit, say, depression in Malayalam, English. I can't do that very well in Hindi, but I can do it better in Tamil. But other languages, it's impossible for me. I've said this. So you need to make ready-made questions which will allow you to probe if depressed mood is present, if depressed mood is present, whether that is lasting most of the hours in a wakeful period of the day, whether that is present more than 4 or more days, then continuously for last 2 weeks. So you can become skilled with this in the next few days if you start practicing. Remember, being a common disorder, you have to screen all your patients for this. Again, the repetition. See, essentially, loss of interest is all about an experience which can be described like this. I am unable to experience pleasure in those activities which were interesting and pleasurable for me. No more pleasurable or less interesting, or I have loss of interest. So again, this is slightly more difficult than the other question. That is, this eliciting pervasive loss of interest is more difficult than eliciting persistent dysphoria. These are the other symptoms. These are very rather easier to ask. Loss of energy, tiredness, a poor ability to concentrate, being indecisive, loss of appetite or increase in appetite, reduced sleep, inability to get to sleep, or sometimes, very importantly, gets up earlier than usual, loss of confidence in doing things, being regretful, having reproach, or feel that whatever you have done is not the right thing, inappropriate guilt, excessive guilt, thinking about death, it would have been better to be dead. Why to live? Should I live on or should I commit suicide? Then the last term is psychomotor retardation. That is a general slowing. If some among you would have seen people with Parkinson's disease, they have slow motor movement. Similarly, a person can be slow both in motor activity as well as responding to questions or talking. This is rather rare and very, but then if you see one, then it is very striking. So if someone has persistent dysphoria, meaning unhappy mood most of the time for the last 2 weeks, or pervasive loss of interest, reduced interest in most of the activities for last 2 weeks, and then you have many symptoms which were listed in the last slide, then you are considering presence of depressive disorder. So you saw someone with depressive symptoms, then you know what a depressive syndrome is. Usually, essential criteria, at least one among the two essential criteria, then four or more symptoms from the other, then you think that that person has a depressive episode. Now, the important task is to find out whether this person with depressive syndrome has what is known as biological depression. This is very important. See, if someone has loss of appetite leading to loss of weight, if that person has early morning awakening, and if that person has morning worsening of symptoms, reports decreased drive in sexual activities, or reports constipation, which is new, and or has psychomotor retardation. If one or more of these symptoms are there, then you should consider that this person is suffering from a type of depression which probably has a biological origin, meaning brain changes more than psychosocial origin. You would have noticed that I had used the term depressive disorders. These are a group of heterogeneous disorders where you can have a mild depressive episode without biological causation, moderate depressive episode with or without biological causation, severe episode most often with biological causation. Whereas when you have a biological depression, you will have loss of weight, early morning awakening, morning worsening of symptoms, and psychomotor retardation. The treatment decision is based on the evidence for biological depression. If biological depression is there, then you need to give a course of antidepressants. All cases would require emotional support and information and education about depression. So we said if someone is getting up 2 hours earlier than usual for the last few months or weeks, then severe loss of appetite, has lost 5 kilos of weight, has guilt or constipation or psychomotor retardation, excessive inappropriate guilt, then you are most probably dealing with depression with biological causation. So drugs become very important there. Again, when you use drugs, you should know the pharmacology, the dosage, side effects, everything. Don't try to learn about too many drugs. Try in palliative care practice, I would recommend that you choose a certain type of antidepressant over other drugs. Once you start using that, when you start finding that people are responding to that, you will become much more confident in prescribing that drug. Now, there is a huge problem regarding the use of antidepressant drugs. See, all of us, Arya, I can continue. No? Is there a need to take any break, take few questions and then go on, or shall I continue?
You can continue, sir.
I'll quickly try to finish. See, all of us, human beings, we become ill. Sometimes we develop symptoms. We take medications. We expect certain things to happen when you take medicines. For example, if I have 102 degrees centigrade of fever, I might take a tablet of paracetamol. And I would expect the fever to come down in the next few minutes or after half an hour. So the expectation is immediate action. Most cases, for example, pain or any other, most often when we start medication, we expect things to improve within hours to days. Whereas all antidepressants have what is known as a delayed onset of action. It takes a week, 10 days, or even 2 weeks for many antidepressants to show its antidepressant action. So this is very difficult for the person to accept. When I have depression, when you are prescribing me medication, I will benefit only after 2 weeks of regular medication. That's something which is sad. So we, as of now, do not have an antidepressant medication which will improve the mood and depression in hours to days. It takes a week at least. Moreover, many of these medicines have some side effects, and the side effects has an earlier onset. I start taking tablet today, tomorrow, day after, I might have the side effect. But the therapeutic effect, okay, right, agreed. So therapeutic action comes later after 2 weeks or 10 days. Side effects appear now. So it is very important that you tell the person who is prescribed this medication about these two aspects. That what are the side effects which you can expect, but don't worry, you will develop tolerance for these side effects and then things will become less problematic. Then 10 days to 2 weeks or after a week, you will start feeling slightly better. So this provision of this information is extremely important because unless and until someone takes medication continuously every day for 2 weeks, you cannot expect antidepressant action to have onset. Now the biggest problem. How do you tell or what do you tell the person when you have depression? This can be problematic. I diagnosed depression with biological symptoms in a person and told him that you, according to me, you seem to have depressive disorder. He refused. He said, no, no, I have no problem which makes me unhappy. So why should I have depression? He said, no, no, your diagnosis is wrong. So there is this popular notion among the public and general feeling that if you are depressed, there is some reason which causes makes you depressed, which simply does not hold true when it comes to depression, which is biological. So this will need explanation. One second, I'll cut off this. Okay. So I want you to recall that I said I had a problem when I diagnosed depression. I suggest he was an educated person. So he said, no, I have no problems, nothing which is making me unhappy. So, but then I held to my diagnosis and said that I agree with you that you have no problem which causes any worrying in you, but you still have depression. So that is not enough. So I try to explain to him about the cause of his depression. This is how I try to explain this to him. Let me do it for you. See, I have brain, you have brain, all of us are equipped with a very important organ called brain. And please remember that mind is in the brain. And we refer to this word mind when we talk about certain functions of the brain. And as all of you will appreciate that most of the communication between brain cells or neurons happens through the chemistry of brain. It is dopaminergic system or something called dopamine, serotonin or some other neurotransmitter, which allows one neuron to say, speak to another neuron or communicate. So normal functioning of the brain means you have normally functioning chemistry of the brain. Okay. So the person agreed, yes. Brain cells communicate and there is neurochemistry which is involved. So I asked him, when you feel sad and when you feel happy, do you think that the state of brain which underlie happiness and unhappiness is it same? It cannot be same. When I am unhappy, the brain cells behave and communicate chemically in a different manner. Unlike when I am excited and happy. That is acceptable for all of us. That the chemistry of the brain, when you are very happy, is different from the chemistry of the brain when you are very unhappy. Okay, he said yes. Now, brain being what it is, it's an organ. Like it's a very complex, highly organized, let us say, computer or whatever. Anything which is working like a machine can have a malfunction. So he was an engineer. He said yes. So when you have depression like you have now, your brain is stuck in that state where most people, most human beings or when they are unhappy. Your brain now cannot shift normally from unhappiness to normal state and happy state. That ability of your brain is no more available with you, with your brain. So it manifests as depression. So it is the persistence of a sad state. I'm sure two metaphors can be, many of you are youngsters, so there was a time when a gramophone disc can get stuck and the same stanza gets repeated. So when you are depressed, you are stuck with depressed mood. Or another example is, I'm sure most of you will not have that experience also. When we were children, when we lived in our rural household, we had electricity, but sometimes, especially in the evening, the voltage will be low. So if you ask whether light is there, it's available, but brightness is not there. So it is as if you have low voltage bulb and your normal voltage is not available to you. So this is how I explained to him. So he said, you make sense. Now I know. So then I told him, I'm going to give you medications which will improve the availability of serotonin in the synaptic cleft. Serotonin seems to be the one which is affected when you have depression. So the availability of serotonin in serotonin system or uh, the functioning of serotoninergic neurons are not normal now. So we said we prescribed him a drug called as serotonin reuptake inhibitor group of antidepressant drug. So it was acceptable to him. So the point which I'm trying to make is that when you have biological depression, you explain like this. Then when you have psychosocial depression, which is related to stress, then you explain to them that stressors, unhappy events, especially when those stressful situation is persistent, most people can go into a low grade or moderate depression, which can be addressed by psychosocial interventions as and also by relieving the stressors which are causing this. So these are the drugs which I recommend that you do not use these old drugs which we were using. Even as psychiatrists, we may still use this. These are tricyclic antidepressant drugs. Biggest problem with these drugs is that it has got anticholinergic side effects like dryness of mouth. You might still want to use dortepin, not at these dosages, but smaller dosages in selected patients. But then I think you must try and use drugs like this. My personal recommendation to you is that you try to use citalopram or escitalopram and sertraline. These are groups of drugs called as selective serotonin reuptake inhibitors. Again, these drugs will have to be used, started with smaller, low doses and then increase gradually. Though the side effects are less, and uh, these drugs are by and large not sedative. Some people might respond with an increase in anxiety symptoms in the beginning. So beware of that. I do not recommend that you use these drugs. I would think that you should become comfortable in prescribing escitalopram and sertraline. Okay. The advantage of sertraline or escitalopram is that side effect profile is better, uh, safe in older people, and then low propensity for drug interaction. Another important thing is when you prescribe this, about 10 to 14 days later, the depression will start lifting, and then you will have to maintain them on these medications for few months, at least 3 months, when there are no depressive symptoms, and then only you can try and reduce. Usually, a 6 to 9 months course may be required because you start low, build up slowly, then you keep that. After the effect comes on, you maintain them at least for 3 months when they are not depressed, and then gradually taper it off. Always reassure the patient about good prognosis. So, these are important things to look for. When someone reports restlessness, you might want to add some short-acting anxiolytics, especially if there is depression. Especially if there is insomnia, we can discuss that. Doctors, when they prescribe drugs, sometimes are not very sensitive about side effects. So it's very important to discuss side effects and listen to their concerns about side effects. This is, in short, depression is so common that everybody should know and be skilled at treating depression. And this is something which I have as an advice for you. When I am depressed, when I'm depressed, I'm suffering. I'm not normal. You should, if you check my BP, do a detailed neurological examination. If you cannot find anything wrong with me, don't ever say that nothing is wrong with you. Because I know that I'm not the same person. So when somebody is suffering, especially from a condition called depression, many a doctor, clinician, or a health worker who is not aware about the concept of depression, who is not skilled in identifying or eliciting depressive symptoms, will make this statement, which, let me put it very mildly, not scientific. When things go wrong, people come to you. When they are depressed, they know that they are unwell, and you will examine, order tests, everything will be normal. Because you are ignorant about depression, you will tell them that nothing is wrong with you. They will think that something is wrong with you. So that's about management. I'll not talk too much about it. But there are many questions people ask, especially in Kerala, and I'm sure educated people all over the world, especially people who are not having good health literacy, or those who have been misinformed about mental health, might ask you, if I take these medicines, will I become dependent on these medicines? Will I have to take this lifelong? These are things which you should make it a point to clarify. Many people ask me these things. Suppose I take medication now, then I start sleeping better. Then, if I stop these medicines, will I start getting insomnia? If I take medicine and then stop medicine, will it affect my fertility, or will something happens to my child? So lots of questions are there. We short get these things, make it brief by saying that all healthcare practitioners should be in a position to recognize depression, assess depression. Is this depression psychosocial in origin or biological in origin? Please remember, this is very important. You decide that something is psychosocial in origin, or I'll ask you that question after I finish. How do you decide whether depression is due to stress or depression is due to biological dysfunction? That we'll reserve for the last. build confidence in the patient, treat, monitor, and last but most important, continue to support and provide good quality care. So this is where we are heading. With this talk, I thank you for this. We will take questions and then probably if we have time towards the end, we will have the last video. Otherwise, questions now, or Arya can decide whether we should take one or two questions and then go for the case presentation. Is that all right? Over to you, Arya.
Sir,
I'm
I think,
stopping screen share.
okay, sir. Sir, I think yeah, we will take one or two questions and later we will move on to the video.
Okay, okay.
Okay, sir. Dr. Payal Advani had already put a question in the chat box. It was sometimes biological depression and progression of cancer both lead to weight loss, etc. What do we do at that time as cancer patients are depressed in general? That was the question.
Yeah, very good question. I think I should not sound personal here. My father had malignancy and he was very unhappy towards the end. And it was very hard for us because he had secondaries. And so when you have metastatic carcinoma and loss of weight, one should presume that loss of weight is due to cancer first. But if there are other psychological symptoms which are suggestive of depressive syndrome, then you should count them and then make a diagnosis because with progressive illness and also among older people, loss of weight may not be due to depression only. It might be contributing. So you will not consider loss of weight as a symptom of depression if there is depression and cancer together. So you will diagnose depression based on other symptoms. Thank you for that very important question.
Please unmute yourself and ask your doubts regarding the topic.
Yeah. Please feel free to ask questions.
Sir, in case of ongoing treatments, if like chronic illness and ongoing treatments, could there be any? Is there any case wherein uh, the ongoing drugs could lead to side effects, and one of the side effects could be depression? And in such a case, what happens? Like the treatment has to go on, and one has to address the depression that has emerged. What happens in such a case? Thank you.
You are suggesting that depression could be due to treatment or the illness.
If any
Yeah.
case.
No, it's a very, in a setting of multimorbidity, one diagnosis of depression is difficult. Number two, the prevalence of depression is also very high in this population. So, if there are depressive symptoms, one thing is definite: you should extend psychosocial interventions, like allowing that person not to get into this chain of thoughts, getting unhappy thoughts, being unhappy and not doing not behaviorally. See, one effect of depression is that you become behaviorally less active. And when you are less active, when you are not able to do things which you want to do, you get more worried. So, improving physical activity, promoting social interactions, and behavioral activation is something which you can try with all these people. Because behavioral activation and physical activity, social interaction will all elevate the mood. So they'll feel better. Another problem is when you have multimorbidity, more than one medication for other disorders, then even when you use selective serotonin reuptake inhibitors, the propensity to develop hyponatremia is very high. So any depression or complaining of tiredness, you should also look at serum sodium levels and correct it. No, I agree with Dr. Kiran Saha that it can be difficult. It can be difficult for the therapist to encourage people to socialize or be active. See, one thing you should not do, or you should not instruct the family members to do, is that don't try to instruct people with cancer and depression to do a certain activity. Rather, you will encourage them, try to get them do it. Uh, it cannot be prescribed like, say, physical exercises during what shall I say? By the physical education instructor will make you do exercises like that. You cannot prescribe. So it sometimes depends on how much rapport you have with them, how much rapport the caregivers have with the patient, etc. So try. Sometimes when you try, you know that you will fail, but you will never feel bad because you know that there are complexities involved here. And when you try to encourage someone to do something and he does not or she does not do it, don't get angry or upset with them because sometimes they are unable to even comply. Oh, yes, this is very important question by Sarita. See, this is something which I thank you for pointing out this. Caregiving is associated with burden. There is high quality scientific evidence which says that longer duration of fairly intense care for a close relative has negative impacts, both physical and mental health impacts on the caregiver. So, all of you should try to see whether the person with cancer or whoever is getting your treatment has depression. Equally important is to identify depression among caregivers. There are simple instruments like PHQ-9 or CESD, or there are simple screening instruments which I can give it to Arya who can circulate this. So these are screening questionnaires which you can use to screen caregivers for depression, or some of these questions with over time it will become part of your evaluation. So that's very important. Caregiver, if there is a caregiver who is depressed, then it is your bounden duty to address that depression. Most of the time, a lot of psychosocial support will be enough. But we have seen caregivers developing biological depression and needing antidepressants. Most of my career in the last 20 years, I spent with older people with mental health problems, and I have treated many biological depressions in caregivers. There were even suicidal attempts. So that's a very important question. I'll send you. We have found CESD, that is Community Center for Epidemiological Studies Depression, CESD, as a very useful scale. I'll send you that. PHQ is there, PHQ-9. Okay. I think with family members, the most important thing is that you should allow them time. And when you offer them dedicated time, it means this. You should see, it is very unusual for caregivers or family members to accept that. See, the caregiver might say that he or she is not the patient, but he or she requires time, your time, where you will be an active listener and the person will be talking about his or her personal distress as well as difficulties which are encountered while providing care for the closed relative. I think that is very important. Yes,
Okay,
I
sir. Can I play the video, sir?
yes. Just
Okay.
listen to this video and then probably we have the case. This is the first video. I recommend that all of you download this video. I'm sure Arya will send it to you and repeatedly listen to this because the accent is Western. It will take some time for you to understand both the graphics and the audio, right? Script.
Okay,
Yes.
sir.
But then, yeah. So we could consider now case presentation. What do you say, Arya? Any question? See, these videos, I suggest that you see this again and again. After some time, you know, because it's not a simple teaching video. It's written by someone who was a very celebrity writer who went through depression, and you could even follow his website. I think he has a website. Yes.
I think Dr. Nanda is there. We'll move on with the presentation.
Please.
Dr. Nanda, are you there? Okay, I will share the screen, ma'am.
Please.
Can you please read it out, ma'am?
Yes.
Hello, ma'am. Please unmute yourself and talk, ma'am.
Good afternoon. I have an unstable internet today. That's why I just go out and come back often. My pranams to Dr. Shaji and all other teachers on this Teachers' Day, first of all. I'm new to palliative care and I'm not sure how relevant is the case to my topic. I have a social science background and this is my humble attempt. About the case, this girl was a volunteer in one of my projects. She was collecting salt samples from kitchen for HPLC analysis. She worked with us for almost 6 years, that is from 2002 to 2008. In 2008, this girl got married to a truck driver. She's from a very poor background. She lost her parents when she was very young, when she was a child actually. So she had a younger sister, and both of them were living with her married brother and family. So when we met her, she was grazing goats and cattle. Now she is unemployed. Next slide. So actually, I'm not a medical person, I have told you earlier. So I have no access to her medical history. At the age of 23, she was diagnosed with HIV. That was during a checkup prior to her delivery of her first baby. At that time, her husband convinced her that it is a false positive and prevented her from taking treatment. He too refused to undergo the test. She's a very innocent girl and she believed him. After 5 years of marriage, she lost her husband to AIDS. By that time, she had one more girl child. I was told by her that both daughters are free from the disease. She's in regular contact with me for emotional support. Next slide, please. This girl is aware that she has a disease and one day she may follow her husband. She's taking the treatment regularly for the past 10 years from a health facility very far away from her house because she doesn't want others to know what is happening to her. The family members know about her condition, but they do not want to have any contact with her and has a hostile attitude. About the prognosis, she herself is not much aware. She's anemic and has joint pains, and she manages her pain and everything with some Siddha medicine or some herbs. And regarding palliative care, she's not at all aware of anything. Her siblings actually do not bother about her at all. So they are not aware of palliative care and prognosis also. Next slide, please. Regarding the genogram, she has 3 brothers. All her 3 brothers and their family continue to have a hostile relationship with her, except a nephew who rarely supports her financially. She had a sister, I told in the earlier slide. Her only sister, she committed suicide when her husband and family started harassing her after knowing about the infection status of Mrs. A. Mrs. A's husband has a brother and sister. The sister is living with her and is the only support that she has. But she is a heart patient too. The brother, husband's brother, a litigation is going on with her husband's brother regarding a property issue. So he too is hostile. She has a strong relationship with her 15 and 13-year-old daughters and her 40-year-old sister-in-law, who all are living under the same roof. Next slide, please. Her neighbors are hostile and she has a court case with one of the immediate neighbor regarding some property issue. And there are, she's from Tamil Nadu, and there are many self-help groups which help them get bank loans and all in Tamil Nadu. The self-help group members in the village also are hostile due to her infection status. They don't visit her. She goes to a distant healthcare facility for all her healthcare needs. So she has no connection with the nearest PHC and its team. But they visit her when there is a mass drug administration program for lymphatic filariasis, something like that. So they come and distribute the drugs to her. So at that time, the health care personnel visits her. Actually, she has no friends. Some friends have turned hostile after knowing about her disease. The school where her children studies and the panchayat have no issues with her, but they have a weak relationship. She does not visit the nearby temples. Community members also, community volunteers also have a weak relationship with her because she leads a withdrawn sort of life. Next slide. She has studied up to class 4. She's from a very economically weak family. But her husband has a house and some land property. But there is a case on the house and land with her brother-in-law. She has leased the agriculture land she inherited from her husband, and that money is the only source of income for the family. She is not employed now. She faces discrimination and she is withdrawn. The social status of her children is also at stake. Next slide, please. Here I have used the word depressed, But after hearing the class, I think I should not have used depressed. I have used meaning that she is unhappy at times. She has a feeling that who will look after my girls after me? So now the sister-in-law is living with her to make the case against her most.
Dr. Nanda, are you speaking? It's not audible. I think there is some issues with the internet. We'll wait for a minute. Dr. Nanda? Okay, then I will read it out. Psychological overview. She is depressed at times, worried about future of her female children, not allowed in social events and so no social interaction, fear of isolation of her children, experiencing high level of social stigma.
I am back,
Litigation.
Arya.
Okay, then
My internet gets it's unstable.
Okay,
So
then
yeah, so she is experiencing a high. She's experiencing high level of social stigma too. And the litigation on the property also worries her a lot. So all these are affecting her mental health. Next slide. So physically, she has tolerable body pain and she has joint pain. So she manages with some herbs and Siddha medicines. And she's weak due to malnutrition. And she has weight loss now. She's only 40 kg. She was 55 when she got married. So physically she's a bit weak, but the doctors have given her some vitamin tablets too, along with her medicine. Psychological, she's anxious about what next. She has a fear, always she has a fear. She's worrying about her daughter's future. She has asked me many times, why me? I haven't done anything wrong to anyone. So this question is haunting her. And she has lack of support. That is, she has no physical support, no social support, no financial support, and no emotional support too. So she lacks support. And coming to socioeconomic, irrespective of the disease, the financial burden of the whole family is on her shoulder. And she's worried about the social status of her children also. So spiritually, sometimes she thinks, what did I do for my suffering? So she keeps away from God for some time. Later, she feels that she needs some relief. So she visits distant temples for relief. Next slide, please. So discussion points, I've just put that is, she herself do not know how and when the disease will progress. She does not have any suicidal thoughts because she loves her children so much. But living an uncertain life with so much of stress, she needs, I feel that she needs some hope for her children. That is, some assurance on the rehabilitation of her daughters will be one thing which can keep her mentally fit. Next, a solution for the litigation on property. She feels that after her, the property will be taken away by her brother-in-law and her children will not have anything. So the property has to be secured for her daughters and some financial help for the studies of the children. Thank you. That's all.
Okay, thank you, Dr. Nanda. I think uh, shall we start discussing this, Arya?
Sure, sir.
I think what is apparent is that she may not be suffering from a full syndromal depression. That is, but then what is definite is that she is HIV positive. She is currently on treatment, but we do not know whether she is declared as based on CD4 counts and all that, whether she can, her counts are normal so that she is functioning at her optimal level. This is typical example of severe stress which is persistent and severe economic and other stress. So I would personally believe that here is someone who is at a very high risk for bad outcome. Like she might go in for a major depressive episode later on, or people like her are at a higher risk for suicide also. Any suggestions? See, this is, I do not know which part, where is she from? Which state is she from?
Tamil Nadu.
Do the government might have a policy regarding rehabilitation of HIV positive people, and is there any policy to accommodate them in labor force or give them jobs? Anything like that?
Actually, I relocated to Chandigarh, so I have only phone connection with her. But
Okay.
she calls me most of the days. But I was not able to inquire about such things.
One suggestion is that, see, there is this large number of HIV positive people who are on antiviral medication, and then they are stable on medication. Disease process is under control. Depressive symptoms are much more common among them. It can come and go. What is important that she should find a job which will help, one, economically, two, she should be able to socially interact with people who will not actively avoid her, who will understand her, and then she might also be able to build social relationships. I think that scare has gone. Only problem is that when you are HIV positive, people would want to know whether you are stable on antiviral treatment, which makes a lot of difference both to the person and to others. So there are so many people who are HIV positive and they declare that they are positive, but then they should also claim that they are stable and their viral load is limited because of antiviral treatment. So getting an occupation which pays her, which allows her to become a participant in the labor force, is going to be very crucial here. Then help of government. I am sure there will be an AIDS control board or under whom there will be some rehabilitation package. Many a time, government sector being what it is, they will try to avoid trying to help these people who are marginalized otherwise. So it would be nice if you could also try and find whether that local area has a governmental officer who will be able to make some difference. Some employers might be able to employ her if they know about their her treatment status. This is very important. Uh, so that is getting back to job, getting back to a regular income, and being part of a social group, because obviously she only has people to support. There is nobody at home who is able to support her. She has daughters and a young sister-in-law, so that's a problem. So, and then as a palliative care professional, you must ensure that she is allowed to meet someone in person and talk to uh, at least once in a month, and over phone whenever that is needed, because physical meetings are important here, because you might also want to look at her face and behavior to see whether she is going into major depression, because she is one of that high risk groups, gender wise, age wise, HIV wise, and chronic persistent stressors which are operational and likely to operate for future. So it would be nice if she could get to talk to someone who is HIV positive and getting through life better. Some kind, because in Thrissur there is this clinic where they all come to collect medication for antiviral medication. They start developing social relationships and they seem to socially support each other. I'm not involved with HIV care now, but when I was the head of the department, we used to support that kind of new networking among people who are HIV positive and continuing to get medication from the same facility. So that is something which is feasible. And feel free to start antidepressant if you think that she has early morning awakening and she looks very slow and is always tearful and things like that. I suspect that if things do not improve, she might, as age advances, our risk for depression also increases. That's another thing. And you should also make sure that she gets the proper antiviral treatment and she is compliant with that, because that itself can help to ward off psychiatric manifestations of HIV. So that was interesting. I was trained in Vellore when they had a HIV program first in Tamil Nadu at CMC Vellore. So those days were very different. That was in the 80s. Somebody had written about YRG carriers. Yeah.
Actually, she's from a remote village in Senji.
Where?
Senji, there is a port and all. Senji. It is spelled Ginge.
Which district? Where is it near?
It is
Tiruvannamalai.
Tiruvannamalai district.
Tiruvannamalai. Yeah?
Tiruvannamalai district.
Oh,
so she's from it's an inside village. So there only agricultural laborer work will be available. She cannot do that. She's weak. So she will not be able to do it. Relocating to some other town also is difficult because of financial constraints. So these things are there, but I have seen someone has given some suggestions. I'll just check those places and get her connected to those
Yeah,
agencies which
Tiruvannamalai,
help her.
there is a psychiatrist also. But at this point of time, she may not require a consultation. But then it would be nice. There is someone who was an alumni who is in Tiruvannamalai now. I forget her name. It's a lady psychiatrist. So there may be, and from Tiruvannamalai, Polur, and this new Vellore Medical College and CMC Vellore is not very far away. So, but as you said, if she is in a remote part of Tiruvannamalai, then things are going to be difficult.
And there is no one to accompany her. And she has
Sure.
studied only up to both class 4. And it is difficult for her to go out of the village. So those things are there. So I'll just try to help her out.
Okay. If you need that phone number of that lady psychiatrist, I might be able to help because she is in our alumni group.
Okay, sir.
So that's very real life situation. This is difficult actually, and that is where your role comes in because anyway, I must acknowledge that there are so much complexity in this case that if we can make a difference, that will be good.
Anybody else has any doubts? I think there is no more doubts. Can I end up the session?
Okay.
Okay, sir. As always, your session was really superb. And the case presentation of Dr. Nanda was also very good. Participants, you really interacted well and you were very attentive. Thank you. Thank you all, especially to Dr. Shaji case. Thank you.
Thank you very much. I am a volunteer for Pallium India also. I am at your service always. Thank you.
Thank you, sir.